Senator Monty, please.
The counties you itemized, how were they selected over other counties?
So the statute has a formula of the allocation, and so when you put additional dollars into it, it just brings up counties the allocation that they get. It's a formula that we can't. If we put $5 million in, we would be able to bring up a certain number of counties. Their allocations may have been a couple $100,000, they might increase. What it also does is there's a base allocation for each county. Each county or each local health department gets $150,000. So in some of these instances, such as I think Solano, Long Beach, they're now a little higher than $150,000.
Thank you. It's based on a formula.
It's based on a formula. It's not a smoking prevalence rate or anything like that. It's a...
Great. Thank you.
Mm-hmm. So the next question was providing an overview of our efforts to inform the public about the dangers of e-cigarettes. So we've done two pretty significant things in the last several months. The first was issuing in January a health advisory, which was designed to inform healthcare professionals about the dangers of e-cigarettes, and then a state health officer's report, which was designed to inform the public about e-cigarettes. So those documents were released in January. In late March, we released a statewide media campaign that features television advertising, digital, and outdoor advertising. So those are the two most significant things we've done this year to inform Californians about e-cigarettes. And then the final question is how we've worked with stakeholders. So we've done a variety of things. In early 2014, we convened a task force of individuals from academia, from other state government, from individual or organizations interested in child health and safety to talk about the latest research, talk about emergent issues related to e-cigarettes, and to help inform us on what might be some of the approaches that we would choose to educate and inform the state, to inform Californians about e-cigarettes. So that was a time-limited sort of activity where we convened, met, and got some information out of the group. We also attended a variety of statewide public meetings that our Tobacco Education Research Oversight Committee conducted last year. Those meetings were developed to develop their state master plan, which was recently released. So the Oversight Committee is charged in statute to release a master plan for tobacco control every 3 years. So the new report recently came out, and our staff attended those statewide forums where T-Rock was gaining input, and we also heard too from a variety of constituents and stakeholders about their concerns or thoughts on e-cigarettes. So we used some of that information. And then we also had a little summit actually at our campus down the street where we brought together a variety of speakers and presenters and educated ourselves as a department on this issue, and had academia, nicotine addiction experts, child poison, the Child Poison Control Center expert, as poisonings are something that we've seen happen as a result of children getting a hold of the e-juice or liquid and ingesting it. And then we also did a few focus groups with e-cigarette users to help us learn a little bit about how folks actually use the product, where they buy the product, things like that. And then we also did focus groups to help develop the actual advertising campaign. And that involved, various e-cigarette users or other tobacco users, kind of the target community of who we would want to focus the campaign on.
We've had lots of conversations, numerous pieces of legislation go through the process on e-cigarettes. So wish we could have come to your summit. It would have been helpful. Senator Monty.
Thank you. And along those lines, as somebody addicted to NBA basketball on TV, I've had the benefit of seeing some of those e-cigarette commercials. they're very effective and powerful. It's great to see it up there in California Department of Public Health. I am interested in, it appears that the trends of young people under 18 getting addicted to nicotine through e-cigarettes, it's now surpassed entry through smoking products. Is that correct?
The data that we have from the California Health Kids Survey shows that youth are smoking the e-cigarettes at higher rates than traditional cigarettes, depending upon the age group or grade that they're in school. 7th and 9th graders at 3 times a higher rate, and 11th graders at twice a rate. And last week, the CDC just came out with the National Youth Tobacco Survey, which pretty much corroborated that same information at a national level.
Yeah, a number of our hearings on e-cigarette legislation, we've heard from the users of the e-cigarettes, and most of those who testify say it's helped them get off of smoking products. But what we're not hearing, and what you just shared, is the on-ramp of young people who this is their introduction to nicotine, and whether it graduates to smoke products or not, they're getting hooked on an addictive substance that's obviously not helpful. Any of your education efforts going into the schools, is any of this happening in middle schools, high schools?
So as part of the health advisory and the state health officer's report, we do want to work with education. CDE themselves is actually using some of their funds to address e-cigarette use within the schools, so absolutely. Our campaign is more focused on community, whereas the Department of Education campaign is more school-based and curricular-based. So absolutely, we're very interested in working with them.
Thank you. Thank you, Madam Chair.
Thank you, sir. Elio? Finance? Any public comment on item 7, Tobacco Health Protection Act of 1988? I'll entertain a motion, please.
So moved.
Thank you. We'll accept the recommendation noted on page 18 of the agenda. Thank you very much.
Thank you.
At this point, we'll transition to item 4260, which is Department of Health Care Services, page 20 of the agenda, and move into the second portion of Part A of today's agenda. Once folks get settled, we'll go ahead and begin with the Family Health Programs presentation.
Great. Hi, Mary Cantwell, Department of Healthcare Services. So there are 4 programs in the Family Health Estimate. First, the California Children's Services Program, which provides diagnostic and treatment services, case management, physical and occupational therapy, and other health services to children under 21 who have CCS-eligible conditions. Those are things like severe genetic diseases, chronic medical conditions, traumatic injuries. We have CCS children who are in Medi-Cal for whom we receive federal funding, and then we do have a state-only program that is funded 50-50 between the state and the counties. The proposed budget for the non-Medi-Cal program is $91 million in the budget year. Sorry, I'm like out of breath walking up. So excited to get up here finally. The second program is the Child Health and Disability Prevention Program, which provides health screenings like child health assessments and immunizations to Medi-Cal kids under 21 and non-Medi-Cal kids under 18 who have incomes at or below 200% of poverty. There's also the presumptive eligibility for kids under 200% of poverty, and they get in through the CHDP gateway. This program is also responsible for the screening component of the EPSTT program. The third program is the Genetically Handicapped Persons Program. It provides healthcare coverage for adults with specific genetic diseases such as cystic fibrosis and hemophilia. And the proposed budget for the budget year is $136 million. And then finally, the last family health program is the Every Woman Counts program, which provides free breast and cervical cancer screening program to uninsured women at or below 200% of poverty, and the proposed budget for that is $423 million. With respect to the CCS redesign process, we have been convening over the last several months a stakeholder advisory board that is also open to the public. We've had 3 meetings so far. The next meeting is scheduled for May 29th. The members of that advisory committee include providers such as hospitals, CCS specialty care centers, physicians. We also have family representatives, county administrators, and other stakeholders who are experts in this issue. There's also have been formed 6 technical work groups out of that board to look at things like the list of CCS eligible conditions, provider standards, the provider networks, performance and health outcomes measures, and things of that nature. Our goal is to complete this process by the summer, and it's our intent that that process and that advisory committee will develop a set of recommendations for a redesigned CCS program. Under existing law, the services for CCS are contracted out generally carved out from our Medi-Cal managed care plan contracts. This statutory carve-out does expire at the end of this year, and we're hoping that as a part of this process, this advisory group will be able to come up with recommendations about what to do going forward for the program.
And that's why I was curious, because we had this conversation just yesterday in Health Committee. Given the current sunset, the fact that you do have a full year proposed funding for 2015-16, and that's because there is an expectation that some form of CCS will continue.
Absolutely, yes.
Okay.
I mean, there's no intention for the program to go away. It's more about how do we improve the operation of the
Whether
program.
it's still carved out or not.
Exactly.
That's the issue.
Yes, yes. There will still be a program, for sure.
Okay.
So any other questions?
Any questions on CCS? Okay. So, okay, wait, let me see. Okay, so are you going to hit CHDB, genetically handicapped persons? You're going to hit all of those? Or are we only focused on CCS on this piece? Got it. I was so busy reading the CCS piece. All right, Elio?
Nothing at this time. We'll review the family health estimate at the time of the May revise, and if we have any adjustments to recommend, we'll let you know at that time.
Thank you very much, sir. Finance? Any public comment on all of the family health programs? Okay, seeing none, we'll move on to item 2, limited benefit and special population programs eligibility requirements.
Sure. So we have a proposed trailer bill for this item. Under this proposal, we are aiming to ensure that individuals who are currently in some of our limited benefit and special population programs that don't qualify as comprehensive coverage are being provided information about, and when appropriate, enrolling into comprehensive coverage if they're eligible. So there are 2 aspects to this proposal. The first is with respect to the GHPP program, and under this proposal, it would be required that for those who are applying for GHPP, that they have to first apply, and if eligible, enroll in either Medi-Cal or subsidized coverage through the exchange. To the degree that there are services that aren't covered, if someone does enroll through the exchange, the GHPP program would continue to provide those non-covered specialized services through a wraparound. The second component of the proposal is for Every Woman Counts, our Family Pact, and our Impact programs. And in those programs, providers do the enrollment. We don't do the enrollment directly at the state. And so under this proposal, we would be requiring that those providers provide information to the applicants about the ability to apply for full comprehensive coverage, but it doesn't require enrollment or an application to happen.
Elio?
Sean Martin, Legislative Analyst's Office. We're in agreement with the staff recommendation to modify the trailer bill language. We have concerns about continuity of care that would be provided to people in the genetically handicapped persons program, and also the details of the wraparound have yet to be determined.
Finance?
Jacob Lamb, Department of Finance. Finance does not support the recommendation made in the agenda. We would like to note that approximately half of all GHPP clients currently receive comprehensive coverage through Medi-Cal and receive their GHPP services as a wraparound. And some portion of the population that is not currently covered by Medi-Cal in the GHPP program are enrolled in other forms of comprehensive coverage and receive their GHP services through a wraparound.
Thank you. Senator Monning? No question. Thank you. Public comment?
Yes, Madam Chair and members, Terry Calgar-Hill on behalf of the Hemophilia Council of California, representing the 4,000 patients in California with hemophilia or other related rare genetic conditions related to the blood disorders. We are respectfully opposing the administration's proposal to require GHPP patients to apply to Cover California in order to keep their GHPP coverage. And the reason is twofold. First of all, while we support Cover California in general, and we supported the ACA, right now, in GHPP, our patients get direct access once a year to their federally approved hemophilia treatment center. And that treatment center the treatment centers are generally located in large academic teaching institutions. They're clinics as part of children's hospitals, a part of UC medical centers, and others. And so our patients can get that once a year appointment with their hematologist that truly understands their hemophilia condition. And then they can get any ancillary prescriptions for their clotting factor, for arthritis drugs. They can get access to occupational therapists and physical therapists. So it's critical because in the Cover California networks, hemophilia treatment centers are not all included in those networks. So our patients would lose that access. The second reason we're opposed to the administration's proposal is that the costs of clotting factor are very expensive. And the co-pays or the cost sharing of the patients under Cover California could be astronomical and cost prohibitive for our patients. Clotting factor is a biological product that our patients infuse on a regular basis, sometimes twice a week, in order to keep their blood clotting properly and to prevent internal bleeding into their joints. So if they have to provide that copay under Cover California, I mean, it could wipe them out financially. Right now, that is all covered under GHPP, and the reason it's affordable is that the manufacturers have mandatory rebates to Medi-Cal, and then they have additional rebates that go to CCS and GHPP that help cover the costs of these expensive drugs. So with all due respect, we support the staff recommendation to carve out GHPP from this trailer bill language, and we look forward to continuing discussions.
Thank you. Next witness, 2 minutes, please.
Tam Ma with Health Access California. We concur with the comments of our colleague at the Hemophilia Council. We also request that the committee adopt the staff proposal to remove the provisions relating to GHPP from the trailer bill language so that medically vulnerable individuals in this program have continuity of care. Thank you.
Chair and members, Kathy Mossberg representing the California Family Health Council, representing those federally funded family planning clinics. We do have to go on record opposing the provision regarding Family Pact in this proposal based on the idea that we don't think it's necessary. Our last Family Pact meeting, we had a presentation done by UCSF where it was indicated that our public providers are moving folks into more comprehensive coverage, either the Medi-Cal expansion or Covered California, to the tune of about 90+%. So we are providing this information. Our providers have some concerns. If this were to move forward, we do want to talk about the trailer bill language. It seems quite vague, and we'd want to make sure that we do continue continuity of care and folks are able to access services and our providers are not overburdened by provision of information. We certainly want to see our folks move into more comprehensive care and are doing that now, so we think this is unnecessary.
Thank you. Next witness.
Paul Neprath on behalf of Planned Parenthood Affiliates of California. We have 115 health centers, and on the FPAC proposal, we see about 900,000 FPAC visits a year. We have seen our FPAC share of our patient load go down significantly, so to associate myself with Kathy Mossberg's point about the relative, I think, unnecessary burden this would place on our health centers, we've been actively involved in enrolling people in Medi-Cal and Covered California and have been an active player in those efforts. We just think that as we're trying to decrease wait times and increase our throughput, this kind of added burden won't necessarily help anybody. Again, I think that if we see we'd like to see the language that's being proposed for our health centers to utilize as this moves forward. Thank you.
Thank you. Next witness.
Linda Way with Western Center on Law and Poverty. We support the staff recommendation to modify the TBL to delete the provisions related to GHPP and align our comments with the Hemophilia Council and Health Access.
Thank you very much. Senator Monning, I would entertain a motion to accept the staff recommendation that's broadly summarized on page 27 that in short suggests that we delete the provisions related to GHPP.
So moved.
Okay, thank you very much. We'll move on to item number 3, modification of Mr. MIP, page 26 of the agenda.
Sure. So again, this is a trailer bill proposal. As you guys know, Mr. MIP was originally established as a state high-risk pool, and the need for these types of pools has been greatly reduced as a result of the ACA, since it does prohibit the denial of coverage based on pre-existing conditions and prohibits charging more to someone because of a pre-existing condition. So in light of these changes, this proposal, from our perspective, is seeking to maintain the original purpose of Mr. MIP, which was to provide coverage to individuals for whom otherwise it would be impossible to obtain coverage that they could afford. And we also think it's important to consider this given the limitations of the coverage that exist in Mr. MIP, and that people really get enrolled in comprehensive coverage that doesn't have the dollar limits that the Mr. MIP program has on it. Under the proposal, Mr. MIP would remain available only to those individuals who are either ineligible for Medi-Cal or Covered California, and they are unable to obtain coverage through the private market. The existing exemptions for affordability of these other coverages maintain as they do today. The modified program would be proposed to be implemented on January 1st, 2016. Our proposal, as noted in the agenda, does contain flexibility for the department to modify the program, and really that's linked to our concern about how do we have a program with a very few enrollees and how do we make sure that it's a viable program. And certainly we would be working with folks on what that would look like, but that was the reason for the inclusion, since we don't know today what that might need to look like. And then finally, the last part of the proposal would extend the time period to reconcile payments for the guaranteed issue pilot or GIP program from 6 to 18 months. With respect to the reconciliation, really part of the challenges are that when the programs came over to the department last year, much of the reconciliation work had yet to be completed. There are still 9 reconciliations for Mr. MIP and GIP that need to be completed, and our proposal would extend the GIP reconciliations from needing to be completed by June of this year to having to be completed by June of next year. This would give us time to complete all the reconciliations. The process involves the plans providing data to the department and us reviewing that, reconciling that to the payments that we've provided, and then following that initial data analysis, entering into discussions with the plan on if there are discrepancies between the two sets of data. We don't know yet the amount of money that the state would either have to pay out or recoup from plans, but based on what we believe is going to happen, we think in the net that there would be a recoupment of funds to the state from the plans.
So that would be the only consequence of the backlog really kind of continuing for another year, is that?
So that we have time to work through those issues.
But the consequence is not that the state could end up paying out more or plans would go without.
No, it would.
That we would end up ultimately probably recouping money.
That is what we believe, yes.
Okay. All right. Senator Monning, please.
I think this was contained in your testimony, but just to be clear, the plan is to maintain Mr. MIP going forward, even with having eliminated the denial for pre-existing condition, which had been this had been the alternative for many, but there's a continued population for whom they'll still be eligible for this.
Yes, so we believe that population will be much smaller, certainly as noted in the agenda, individuals who have ESRD, this would obviously need to continue for that. And then if there are other individuals who aren't eligible for coverage through Medi-Cal and the exchange and aren't able to get affordable coverage through the individual market, this would be maintained as an option for them.
Great, thank you.
Leo?
Sean Martin, Legislative Staff Analyst Office. We agree with the staff recommendation to hold this open to address the issues that are outlined in the agenda.
Thank you. Finance? Public comment?
Tam Ma with Health Access California. We generally support the intent of this trailer bill language because it would maintain Mr. MIP for individuals who are in Medicare, ESRD individuals, so they could purchase supplemental coverage, and it also maintains Mr. MIP as an option for non-ESRD individuals who are in Mr. MIP today. We also note that this proposal is an improvement over the administration's previous attempts to eliminate this program outright. We would like to see a stakeholder input process be included in this proposal as the department goes about making changes to the program, and any changes should be subject to legislative approval. We also have some concerns about the proposal as it relates to Mr. MIP as a safety net option would be eliminated. We don't think that should be the case, and we support the staff recommendation to keep this item open.
Thank you very much. Next witness, 2 minutes.
Linda Way with Western Center on Law and Poverty. We appreciate the staff's recommendation to hold open as we are concerned with the proposal that current Mr. MIP enrollees would lose access to Mr. MIP coverage if they failed to apply for covered California coverage during open enrollment. Considering the issues DHCS has in sending out accurate and timely notice for other programs, we recommend that individuals be allowed to remain in Mr. MIP if they fail to enroll in a comprehensive plan during open enrollment.
Thank you very much. We'll hold this item open. We'll transition now. Items 4 through 12 will focus on the Medi-Cal program.
Great.
And we'll begin with the Coordinated Care Initiative, CCI.
Sure. So as of April 1st, we have about 122,500 individuals enrolled in the Cal MediConnect portion of CCI in the 6 currently active counties. As you all know, passive enrollment will start for Orange County, our 7th and final county, in August. Unfortunately, the opt-out rate does continue to be higher than we'd like. We are at about a 50% opt-out rate. One thing to note is LA does have a disproportionately high opt-out rate, so if we exclude LA, we're at about 38%, which is closer to what our target was, certainly than 50% is. On the other end of the spectrum is San Mateo County, who has the lowest opt-out rate at 13%. For Cal MediConnect, we are transitioning out of the passive enrollment phase. That was originally the 12-month period where we were enrolling people essentially by birth month. So that will end. It's already ended for San Mateo. We have 3 other counties ending this month, and the County of Los Angeles will end in June. So we're really moving to an active enrollment phase where it's really about making sure the information is out there and that people are aware of the option and can choose to opt in and enroll, but we aren't doing sort of an ongoing enrollment process anymore. For the managed long-term services and supports component, we will complete enrollment of all of the individuals and the inclusion of the benefit at the end of June for Riverside, San Bernardino, San Diego, and Los Angeles. There was a question in the agenda about the demographic analysis that we've been doing on the opt-outs. We have been looking at that in a very detailed way, really doing descriptive statistics, looking at ethnicity, language spoken, what plan the person was coming from, zip code, county, and all of that. We're still working through our process to have that data available to post publicly. Our hope is to have that sometime in the middle of next month that we'll have it up, and sooner if possible. Some high-level info that we did see, generally we are seeing the highest opt-out rates in populations of Korean, Chinese, and Russian descent in most counties. For example, in Los Angeles, both for Korean and Russian populations, we are seeing an opt-out rate of about 90%. Another example is in San Diego County. The highest opt-out percentage is for the Chinese population. It's close to 60% compared to the countywide opt-out of 40%. So those are the things we're looking at and having that help really inform our education and outreach both to beneficiaries and providers. We're working closely with CMS to better understand the reasons for opt-out. We are not unique in the country. A lot of states are experiencing these significant levels of opt-out, and so we're all really working together to assess what do we do going forward to move from a passive to an active enrollment to really help people understand the benefits of the program. We have been meeting with health plans, providers, counties, and other stakeholders to first really talk about how's the program working, how can we improve it, make sure that the interdisciplinary care teams and the care coordination that really were the promise of Cal MediConnect is happening. And we believe if we're able to do that, we'll have stories and examples for people to understand how the program can actually work for them, and they would be encouraged and want to apply into the program. We've also given some of our analysis here that there are particular ethnic populations that are much less likely to want to enroll in the program. We've been reaching out in particular to ethnic physician associations to really help educate there and help them understand both from a provider perspective the potential benefits, as well as seeking out if they would be willing to be partners with us to talk about Cal MediConnect with their beneficiaries. And then we've also been using this information to help with Cal Optima as they're planning to do their rollout for August, that really build on lessons learned from what's happened in terms of the amount of education and outreach that needs to happen in order for people to feel comfortable with the program and really want to enroll in what we believe at the end of the day is a better system, to have an integrated system and not have to be working in different silos. The third question was about our healthcare options call center. Since October, we have been working very closely and had enhanced efforts to improve the beneficiary experience. We do have staff from the department on site at the call center 3 days a week to monitor performance and provide training to the customer service representatives. We also engage in the ongoing training of all of the customer service representatives, including new hire training, and we review all of the materials that are used to answer questions, and we update the staff regularly on any policy changes or any new information that is needed for them to continue to do their jobs. Our staff also record calls daily, and we really focus on the newly hired customer service representatives, so those who are in their first 6 months, and we provide feedback and instruction, and we work on issue resolution. We also have Harbage Consulting, who have been implementing weekly secret shopper calls that are both designed to test the knowledge of the customer service representatives, as well as if we hear issues from stakeholders, we then have Harbage do a secret shopper call that's really targeted to those issues to see if we can also replicate that and then figure out ways to resolve those. We do have twice weekly leadership meetings between the department and Maximus to review any issues that are going on and to continue to work on improvement of the call center. And then finally, regarding the issue of MSSP, I think you know that as a department, we do view organized delivery systems and the integration of all of the benefits into managed care as a full continuum of care as being the best direction for beneficiaries. And so that's why we've been working on the transition of MSSP, given our plans have the full spectrum of other home and community-based services, long-term services, as well as acute services, that this is another benefit and option for them to use to best manage the population, and particularly those who are highest need and really do need to use MSSP services. Certainly, we are aware of the concerns about the timeline of the transition, and we certainly agree that we need to make sure that the transition is done in a way that plans and sites are all ready to have the full integration. And so we're certainly open to ongoing conversation about whether there's an extension of the timeline and what other actions we really need to take to make sure that the transition is done in the best way possible.
Thank you. Elio. Finance. Senator Monty. Public comment. Clearly, they were waiting to be invited.
Linda Way with...
I just want to remind everyone that I ask that you limit your comments to 2 minutes. Feel free to say ditto if an advocate before you has made your point as articulately as you would. 2 minutes, please. First witness.
Linda Way with Western Center on Law and Poverty. We support the staff recommendation to leave open and the need for real-time data to evaluate if CCI is meeting the goals so that we can focus on the quality of the program. We believe if the program is working well, that this is a far better way of attracting members and increasing opt-in rates than any marketing campaign.